All right, so our case, 74-year-old female, came in with decreased PO intake, fatigue, confusion, oliguria, after being treated for pneumonia outpatient 1 week before. She was initially hypotensive, started on pressors, and was confused. Past medical history, hypertension, hyperlipidemia, hypothyroidism, AFib, prior strokes, deficits, no surgical history. Medications, she was on Eliquis, high blood pressure medications, Lasix, Synthroid, aspirin. Social history was her family. Initial vitals when she first came in, hypotensive, tachycardic, lethargic, still ANO times 3 at that time. Their abdomen was mildly distended. Her labs, she had a white count of 18. She came in with a renal failure. Creatinine was like 4.7, potassium 8.2, hyponatremic. And then this was her CT findings. Looks like she had a perforation right in her duodenal bulb with some gas and liquid. And you can see on both imaging. On day 2, started on dialysis. She had an X-lap where they did a primary repair of the duodenal perforation, suspected fistulization of the gallbladder. They did an open partial cholecystectomy on day 2, and then they packed the liver and retroperitoneum. Day 3, they had to repeat the X-lap, do a completion cholecystectomy. They did a modified Graham patch for the duodenal perforation, removed the liver packing, and then placed the GJ tube. And so we were consulted about 2 weeks later, where they did a CT scan, and they were showing that there was leak of oral contrast into that collection, as you can see from the arrow. She was very sick. She was hospital course complicated by acute hypoxic respiratory failure due to pneumonia. Was on high flow. The infection, she's been on antibiotics, and then this ongoing leak for 2 weeks. So we did endoscopy, and so this was about 1 centimeter distal to the pylorus. You can see the sutures where they did the primary repair before. When we injected contrast on fluoroscopy, you can see the huge leak right there with the blue arrow. We ended up doing replacing an endovac. We used it using a modified surgical sponge, using a 16 French NG tube, and then we used continuous suction. And then we repeated the EGD about 3 weeks later, and so you can see the perforation looks a lot larger than it was before. We didn't use too much insufflation the first time, but and then through there is already a CT guided drain placement and a surgical drain that was already in there. And then this is our endoscopic video at that time. This is us in the antrum going into the bulb. You see the
And you guys might think,
fistula.
because I think last year I also presented endovac case, which didn't quite go as planned.
It's the drain,
Perf
yeah.
drain that is in there. And we actually love endovac. I wanna,
I need to learn to love it, but I don't right now.
like we use it all the time, but we run into challenges. So what would you guys do next?
And so the summary had the duodenal perforation, waited 2 weeks, did then replace an endovac.
And the
So how
surgeon,
many
trauma
weeks-
surgeon come to us
How
and say,
many weeks out are we
please.
now? We're at
About
week 4?
We're 35 days from the initial presentation, and she's had the endovac in for about 3 weeks. I think it was like day 20.
Obviously, so primary closure, not a good idea. The tissue looks terrible.
Okay.
So now you tried endovac, it didn't work, so we got to divert secretions. So he has one I know from his partner he can talk about, but you could try like a Taiwu fully covered esophageal stent and suture the hell out of it in the antrum so that it doesn't migrate, because that's obviously a risk. We've done that, and then his partner is published on the.
So it's we've done quite a few cases now. So it depends on like where the perforation is. Is it preambulary or postambulary?
Preambulary, just
Yeah,
about.
so no, here,
yeah.
this
Yeah.
one we know that. What I'm saying about the treatment,
yeah.
So when these chronic perforations, which are not healing surgically without endovac, and then you have to do exclusion, so then you need to figure it out the actual place. Is it pre-ambulary, post-ambulary? A little bit different options, endoscopic options for that. But the goal is to divert those. If it's pre-ampullary, then you don't need to worry about liver secretions, pancreas secretions, which can go up to liters a day or something like that. Because if you don't take care of those, that's going to continue to leak. So in this case, what we would do is like do a pyloric exclusion and GJ.
It's very cool, I mean, 'cause
What,
I can't
what were
describe
your
it.
thoughts from that?
No, I mean, I'm glad I heard about this, because I was not thinking about
Yeah.
that before, so, but we have had, one of our partners had a recent case, it was a duodenal perforation, but we used, your idea of the Taiwan is good, we've also used the Boston has a,
Agile.
the Agile, the partially covered has a very cool design that minimizes, we actually had a DDW, one of our fellow presented on it, but it's got covered, uncovered, covered, uncovered, and covered. So we've been using it for esophageal leaks without suturing and being able to remove it, because
problem removing.
you can invert it, the whole thing out. It's really, I'll show you, it's really cool
I
actually.
haven't used the Agile,
Yeah, so-
compared to Taibu, the radial force is still pretty good.
It's pretty soft, which we
Yeah.
like for these leaks to get it
True,
out.
yeah.
But our partner did it in a duodenal one, just like that.
Because there's some partially covered or uncovered, it's not migrating.
It's not migrating, but you can still retrieve it, but we're not
Yeah.
waiting more than,
Yeah,
6 weeks.
Yeah,
4 to
otherwise
6
there
weeks
will
at
be
most.
Yeah,
tissue
I would-
ingrowth into that.
Yes.
And
No,
that
but
will
even-
be a
But
It
problem.
has
even
it.
for putting it in proximal into the stomach, he didn't suture nothing?
No.
And it stayed?
Yeah, because.
So partially covered, that's
Yeah,
it.
I'll show you later why it's like,
Yeah.
and it's got purse strings on either side.
Yeah.
So what we do is, you can't just pull it, even if both ends have the ingrowth,
Yeah.
intraesophageal, you won't be able to pull it out. But you go to the distal end, you grab the inside, the whole thing inverts out. It invaginates into itself and it just comes off the
This
tissue.
is amazing, in 15 minutes you gave us like
Yeah.
3 different
Yeah.
ones.
But he
What
just
to
did
do.
that same thing for this, and what's cool though is also, if you're truly trying to exclude, I don't know how well did he have it in the bulb? I don't remember where he
No,
put
it
the
was,
button.
it was deep, it was like in the third portion.
Oh, so
of the
it was
duodenum.
completely
It was
deep.
after an ERCP at another facility and he thinks they like shot.
But it'll also then, the partial covering allows the secretions not to get, with the tissue ingrowth buildup,
Right,
Yes,
secretions
nothing
get,
goes through.
Yeah.
And the main thing about the stents is you have to be careful not about the ankle.
Yeah,
Because it
and not
can
to block
cause
it. Pain.
ampullary compression
Yeah,
and pancreatitis and the biliary obstruction. So that's what I worry about, these ones. For us, probably we would try a pyloric exclusion on this. The
I
reason-
would now, but in the past,
Yeah,
we did Taibu.
yeah.
And we would suture because over the stent fix, I don't know, in the stomach, the wall's pretty thick, so
Yeah.
it doesn't really grab it that well.
And you have to do a full thickness sometimes. of
Yeah,
those.
yeah.
And you do a full thickness suture and that grabs it. The thing, if it was post-pyloric, then that's post-ampullary, then it's a problem. In those cases, sometimes you have to do a ERCP and put a very long stent from the bile duct, double pigtail into the distal part of beyond the area of perforation.
To allow the
To allow the secretions
biliary
bypass.
bypass. Ah, I see.
And the same thing is with the pancreas too. So it bypasses that area. It may not completely do it, but that does help. And then do the pyloric.
We kind of did that with our gunshot wound. We
Yeah.
did a duodenal leak right on the opposite wall of the ampulla.
Yeah.
But
But
IR was the
different
one who
case,
did it.
different-
Yeah, different case, but
Different case.
yeah.
So here's what we did.
So pyloric occlusion. We looked at endoscopic GJ, but there was no window. There was
It
no.
was a really bad, we couldn't find a window where we could safely put that in despite multiple attempts.
Yeah, and surgery was very hostile abdomen, so they didn't want to do anything.
So,
This was on day 73, so it's another like a month
Oh,
later.
wow.
Yes.
man.
So then talking to trauma surgery, you got the ongoing leak. We ended up moving the pigtail sens that they placed before. We did APC, hemoclip placement, just trying to make it smaller. The peg was in place beforehand, and then we did the pyloric exclusion with endoscopic suturing.
And we did full, like you said, we attempted to do full thickness with the helical retractor.
Yeah.
And we
Yeah.
closed it and then we put like a second layer on top of it.
That's what was gonna, you have to do a second
The
layer.
second
but
layer
yeah,
just
Just
to
for
cover
nutrition,
it.
what did you do?
Well, unfortunately, we had to do the TPN.
TPN.
Yes.
I mean,
And, but what about the gastric juices secretion?
Yeah, so we
they had a
were,
peg.
Peg.
and
You
we
had
should
a
already
suction.
had a peg
Yeah.
and we were suctioning through
Yeah.
that.
Yeah.
Yeah, so that's.
So we kinda
yeah,
knew,
that's just
yeah.
a video.
Because then one time it stopped suctioning, and we're like, okay, then we had to go in there, and so it was easy. We got feedback right away.
Yeah, exactly, because we were worried that if it's nothing coming
Oh,
out,
then
then
you
it
knew.
means that something wrong
Something
with
is-
that.
Right.
Yeah.
That is
So we
forward.
knew.
So we can show the final kind of, yeah, this is just
Just
suturing.
skip the
We
video.
can move along to that.
What's your experience with the usual double channel for the overstitch
Yeah, that
versus
is a
the
great
single?
question. I want to
You know,
know.
versus the
answer
newer-
I
that.
haven't used the newer one,
Newer one, I don't think it's that great. That's it's.
I think it's
Uh,
better
it's a-
though than the original single channel.
I don't think it does the suturing that great,
In
but
terms of
the double
grabbing.
channel, grabbing it. that
We
does it.
only use double channel
I only use
because
double.
if you get in trouble with suturing,
Yeah.
having that second channel
Yeah.
save us
Yeah,
multiple
so-
times. So
Yeah,
we
we
don't.
don't even
This
know.
location though, pylorus, I mean, I think is pretty straightforward. I tried to suture a Perfum D3 with a double channel, it didn't work.
Yeah.
Oh, X-Tac worked, surprisingly
Yes.
well in
Yeah.
that case. Granted, it was
Oh.
fresh,
Yeah.
but because I think the duodenal mucosa is thinner than in the colon,
Yeah.
that worked
Oh, it really
amazing.
got-
Huh.
So,
Brought it together.
yeah, it really did, and she did great.
Did you
And
burn
D3
the
though, obviously
edges?
she wasn't as sick, she just had pain and some fever.
Did you burn the edges when you were closing, or you just used the
No.
extra?
I put Ovesco that didn't work, I did through the scope, didn't work, I tried suturing, didn't work, and then out of desperation, I said, give me X-Tac. Then it worked, and so I didn't APC anything. It was so far down too, but, and I just scoped her, she's doing well.
I'll show a video tomorrow, just like for the Ovesco. It's
Yes.
a very short video, like for perforations. You can make a really patch yourself for a bigger
Yeah.
perforation.
Yeah.
And make it if duodenum or colon, if it's acute perforation, then you can put that Ovesco. It's like you use a rat tube through the Ovesco or padlock, whatever you're using. Grab the distal part of the like mucosa, like a fold or two folds. Pull that over the perforation, and
And
then
then
apply.
deploy the
So
clamp.
you make a patch.
Yeah.
I see.
Yeah, so it's
Clamp it down.
you get clamped and with it, and it's
That's a great thought.
yeah. So it's and then if you gotta close, you can use more regular clips and
Yeah.
just put it on the sides.
When you do pyloric exclusion, this was our first case, and then we probably saw your guys' videos, and that's why we did it. So how long do you keep it sutures?
So this is what you do. You do is like 8 weeks. Keep those sutures there. Bring them back. Cut the suture.
Right,
Okay. Then do a contrast through that.
yes,
And then if it's not healed, redo it.
right.
And so
We
that's
were
what-
too impatient, we did it in 4 weeks.
Oh,
Okay.
good Lord.
I think I would give a little bit more time. We
Yeah.
usually
I
give
felt
6
that.
to 8.
Okay.
I was gonna
We
say, I
couldn't
went
wait.
6 to 8.
We couldn't wait,
when I
we were
do
like
the-
dying to
when
know.
I-
We were
I've
on
been
the-
here.
When I do the stents, I do 6 to 8.
Okay, so
Yeah.
we were like 4 weeks on a day.
Wow.
Trauma surgery kept pestering us. What are we?
Well, we just couldn't wait any longer. That's
So
the
excited.
reality.
Yeah.
So excited. Yeah, and then closed, there was no. And then,
Yeah.
Oh, nice.
So sutures removed.
So yeah, if you had done a EUSGJ, who don't
Yes.
if it has closed, then you can pull the stent out. If otherwise, leave that in. If still a leak, and just close
Yeah.
it and send them. Then
So she actually left, we can show the, I think we have a little video of the end. And, I think the reason we went back soon, because I kept on worrying that we didn't do a good job suturing it. So it really was still closed. We tried, you can probably move it along, and this is the plan. So it was,
still closed.
it still was closed. We could, it's not, I don't think it's a perfect seal, but it was
No,
close
but it's
enough.
enough, right?
It was close
And
enough.
I think PEG tube was helping
Yeah.
quite
Yeah,
a bit.
yeah,
Because
that's
if there was a,
decompressing
yeah,
constantly.
that's a constantly decompressing there.
Yeah,
And that's why the GJ helps with that constantly.
Was the peg hooked up to suction at all, or?
Yeah, we were,
Yeah.
we
You had
were
it.
like, at that time, we put it to lower.
No, okay, yeah, that's what I was gonna say. I
To,
was
to
just-
suction,
Yeah.
yes. Yeah, we could go to the very end, I think.
I agree, because you had it on both sides.
Yeah, and this is,
Yeah, just the video of the.
just a video, there was a little granulation tissue,
Yeah.
yeah, there's nothing there.
Nice.
And she left alive.
Wow.
The thing is, her hospital, we didn't cover it, but her hospital course was just horrendous.
Yeah.
There were multiple respiratory failures that
Oh.
were, so we were cautiously optimistic that.
So just the summary: 74-year-old female, decreased PO intake, duodenal bowl perforation, gas, hospital fluid collection, and then 3 weeks endovac placement, pyloric exclusion. Yeah, we kind of covered all.
I think we covered that. So we'll keep it longer and consider stenting, although,
No, but now I like this pyloric.
yeah, she
Yeah.
was,
Yeah.
but we didn't want to
Yeah.
sit that long with her being at the end.
I think it's just also how risk tolerant is that patient? you know,
No,
for
it
different-
was at that point, yeah, and that
Oh.
is, yeah.
Yeah, my boys.
Nice job. I think you can graduate.
Yeah, I was gonna say.
Okay,
Thank
so-
you, thank you.